Pharmacist, Miss Lin. She is a master degree of pharmacy in National Taiwan University. So she has a lot of experience on pharmacology and how to use the medication in clinical practice. I think you already listened to the lecture. It's very active and I think you learned a lot from yesterday's lecture. So let's welcome Ms. Lin.
Hello, good morning. Good morning. Okay, we don't have a game for today because today this is a very important topic, so we will be more focused on this one. And so in this session, we are going to look at the pharmacology of anticoagulants and antiplatelet agents. And for anticoagulant, it is primarily used in the in venous thrombosis. And for antiplatelet agent, it is usually used in arterial thrombosis. But both of them are very important. Okay. And I think this one is not too unfamiliar for you. You know that one, right? This is the coagulation cascade. Because before we go to look at the anticoagulants, you have to know about the physiological mechanism of coagulation in the body first. Okay, this is the coagulation cascade, and I'll just try to give you a brief review. There is the intrinsic pathway and the extrinsic pathway, and different coagulation factors are involved in each pathway. But the two pathway will comes together at the level of factor 10, and then the factor 10 will further activate factor 2, also known as prothrombin. The inactive form is prothrombin, and when it is activated, it will become thrombin, and then it can facilitate the activation of fibrinogen to fibrin. Okay, and for the intrinsic pathway, it is initiated by this one, the factor 12. And factor 12 is activated when it is exposed to endothelial collagen, the subendothelial components during the vessel injury. So after factor 12 is activated, it will further activate more downstream factors such as 11, 9, and then 10. And also the factor 8 is involved. You can see that the 8 is the activated form. Yes, it is also involved in the activation of this intrinsic pathway. And for the extrinsic pathway, the activator is different. The activator is tissue factor. That is something that not naturally exists in the blood circulation under normal condition. The tissue factor is released by the damaged cells during like trauma. And you can see that the tissue factor can activate factor 7, and then factor 7 will further activate factor 10. So this is the coagulation cascade. So afterwards, there will be the formation of fibrin clot. And then there's also a mechanism for anticoagulation to maintain the homeostasis. For the fibrinolysis, you know that plasminogen is involved. The plasminogen is activated to plasmin, and then this one is in charge of the fibrinolysis. Okay, so after you understand the whole mechanism, we can see how different class of the anticoagulant target at. You can see warfarin is here. Warfarin. It is an oral anticoagulant, the traditional form oral anticoagulant, and we are using it now very often in our country now. And you can see that warfarin target at many different factors, like factors 9, 10, 2, and also factor 7. So it has many different target sites. And heparin is here. Heparin target at factor 10 or factor 2. And aside from heparin, we also have the low molecular weight heparin that also belongs to the heparin family, but it has different molecular structure. It is shorter in the molecular structure. And we also have the fondaparinix. It looks like heparin. Yeah, also looks like heparin and acts like heparin, but it has more specificity towards the factor 2. No, I'm sorry, factor 10. Aside from that, nowadays we also have some newer generation oral anticoagulants. They are known as novel oral anticoagulants, or some people will also call them direct oral anticoagulants. And they can target directly at factor 10 or factor 2. Yeah, they are known as factor 10 inhibitors or factor 2 inhibitors. Even though they are not very widely used in Swaziland right now, but they are very popular around the world today. Okay. And so these are the indication of anticoagulants. As you can see, the coagulation cascade we have just mentioned are predominant in the venous coagulations. So we can know that the anticoagulants are primarily used in the indications involved venous thrombosis, such as atrial fibrillation, stroke, or pulmonary embolism, or DVT, or even valve replacement. We will also use that. And okay, so next we are going to take a closer look at warfarin. What is the mechanism of warfarin? Which vitamin? K, yes, vitamin K. Warfarin, we very often say that it is a vitamin K antagonist. This is how it works. Because warfarin target at an enzyme called this one. It's quite long, vitamin K epoxide reductase. To make it short, you can call it VK or a VCOR enzyme. And anyway, this enzyme, this VCOR enzyme, is responsible for the activation of vitamin K. This is the inactive form vitamin K, and this is the active form of vitamin K. And you can see that in order to activate vitamin K, you need this enzyme. But warfarin blocks here. It inhibits this enzyme. So that's why vitamin K is that's why warfarin is a vitamin K antagonist. And you may think that, oh, what does vitamin K has to do with coagulation? Okay, then you have to see the upper part. Vitamin K is responsible for the activation of various coagulation factors, such as coagulation factor 2, 7, 9, 10. They need vitamin K in order to be activated. However, aside from that, because in our body we also have the naturally existing anticoagulation factors, the protein C and protein S. Okay, I forgot to introduce. Protein C and protein S is here. It inhibits the activation of factor 8. So they are the anticoagulation factors. Okay, so go back to this one. So you know that vitamin K not only responsible for the activation of coagulation factor 2, 7, 9, 10, but also responsible for the activation of the anticoagulation factor, protein C and protein S. Okay, and the reason why that I mentioned protein C and S is here. Usually when we give warfarin in the clinical practice, we need to wait for a while. We need to, not for a while, for several days for the warfarin to achieve its full efficacy. That is because its onset is kind of like delayed. And the reason, the mechanism is here. It is because you can see this chart. I'm sorry that I think it doesn't have a Okay, comes out. Factor 2, 7, 9, 10. Most of them have relatively long half-life, which means that when warfarin goes to block vitamin K, and you can expect that these factors, these coagulation factors will decay after you give warfarin. However, because they have a longer half-life, so you have to wait longer for them to lose their efficacy, for them to decay. And at the same time, you can see that the one protein C, the one in the red rectangle, it has a shorter half-life compared to other factors. Its half-life is 9 hours. So what will happen is that the anticoagulation factors will decay first, and the coagulation factors will decay later. So that's why together it will take time for warfarin to achieve its full efficacy. So what is very important is here on the bottom right. Usually when we give warfarin, we have to overlap warfarin with parenteral anticoagulants. Usually the parenteral anticoagulants have quick onset and short acting. And usually we can give like heparin or enoxaparin. Yeah, they are parenteral anticoagulants. At the beginning of giving warfarin, you need to overlap them together so that the patient won't have a coagulation effect at the beginning of the therapy. So this is important. Okay, and this one is important too. Warfarin, there are many factors in our body that can influence the efficacy of warfarin, because these factors may influence the absorption or the distribution or even the metabolism of warfarin. So in some situation, you may need to adjust the dose. So that is also why when you use warfarin, you have to monitor. You monitor what? INR. Yeah, INR. You have to monitor INR, and you also have to monitor the coagulation response. You have to monitor very often. Okay. However, different patient has different. Different patient may has different desired target INR. Depends on the indications or the clinical needs. Okay, so these are the factors that may influence the dosage. Let's see the upper part. For example, if you use warfarin with other drugs that may induce the metabolism of warfarin, such as rifampin or carbamazepine, you know that they are the liver enzyme inducer. So they will enhance the metabolism of warfarin. So under that situation, because they enhance the metabolism, so you may have to give more warfarin. You may have to give higher dose. Okay, and this one's important. And another one is dietary vitamin K. The high dietary vitamin K intake will also reduce the effect of warfarin, because we have just mentioned, you know that warfarin is a vitamin K inhibitor. It is supposed to inhibit the effect of vitamin K. So if you eat too much vitamin K, then it will counteract the effect of warfarin. So that is why dietary vitamin K is also important. And also smoking, yeah, there are also some data showing that because smoking will induce the liver enzyme CYP1A2, so it may also enhance the metabolism of warfarin. Okay, so these are the situation when you may need a higher dosage. And let's see the bottom part. Okay, in some other situation, you may need lower dosage. For example, of course, if you have elevated baseline INR, you may need lower dosage. This is quite easy. And another situation is poor nutrition. Because under poor nutrition, you may intake, for example, less vitamin K. So in that situation, so it's opposite from what we have just mentioned. If you have lower dietary vitamin K intake, then the effect of warfarin will be enhanced. Okay, and for example, in diarrhea, it is also associated with absorption. Yeah, in diarrhea, you will have poor absorption. And also hypoalbuminemia, if you have lower albumin. This is because warfarin also binds to albumin to a large extent. So if you have lower albumin, then there will be more free warfarin. Because free warfarin, the warfarin that is not bind to the albumin, is the albumin that actually takes effect. So if you have lower albumin, then the efficacy of warfarin will be enhanced. And there are many factors, and other important things are like genetic polymorphism. For some people, they have some genetic mutation in their liver enzyme, especially the CYP2C9 enzyme, or also the enzyme that, the VCOR enzyme, the one that warfarin target at. Yes, this will also influence the metabolism. Okay, and for drug reducing, that can reduce the metabolism of warfarin because it reduces the metabolism. So more warfarin will remain in the body. So in this situation, you may also need a lower dose. Okay, and foods. I try to summarize some of the foods that are high in vitamin K content. And many of the foods are the green vegetables, the green leafy vegetables with a lot of leaves. And I think many of them are quite common in Swaziland. For example, this one, I think this one looks like what we call spinach, yeah, in the supermarket or in the market. And also kale. Oh, this one looks like cabbage, but I know some kale also looks like spinach, like this one. Yes, they are rich in vitamin K. And also lettuce, especially the one with some red leaves. And this one, I think, it is also common. The real name is called Swiss chard, but I remember that in some supermarket, we also call it spinach. Yeah. And also tea and liver are rich in vitamin K. So those are the foods that you may have to be aware of and have to educate the patient and let them know. However, it does not mean that the patient cannot eat them at all. What is important is that it is more important that you do not change the dietary habits once a patient is already stabilized on the warfarin therapy. Yeah, just keep a constant intake, a regular dietary habits. Don't eat a different kind of foods all of a sudden and eat a lot. Yeah, just keep a constant intake of vitamin K. Okay, and this one is about the heparin family I have just mentioned. This is unfractionated heparin and low molecular weight heparin and fondaparinux. Their mechanism are quite similar, and this picture is just try to illustrate the mechanism. The heparin family, they target at factor 10 and also the thrombin factor 2. However, their specificity are different. But before that, we have to know the heparin family, they do not interact with factor 10 or the factor 2 directly. They need a cofactor called antithrombin in the blood. This is the unfractionated heparin. It's a long chain, sulfated mucopolysaccharide chain. And it binds to the cofactor antithrombin, and then the antithrombin can help it to interact with factor 10 and also helps it to interact with factor 2. So that is how the heparin go to interact and inhibit the activity of factor 10 and 2. And what I try to show here is that for low molecular weight heparin, you can see that because it's low molecular weight chains, the molecule chain is shorter. So, but the short chains does not influence its interaction with factor 10. But what's interesting here is that because in order for the heparin family to interact with factor 2, the interaction will be stronger if the molecule itself also interact directly with this thrombin factor 2. But you can see that for low molecular weight heparin, because it's like the arm is too short, it cannot touch the factor 2. So you can see that the interaction with factor 2 will be reduced. So that is why low molecular weight heparin has weaker interaction, weaker inhibitory effects on factor 2. And for the fondaparinix, it is even shorter. It's just a compound that mimics the binding site of the heparin and low molecular weight heparin. So, but however, because it can still interact with antithrombin, so the factor 10 effect is okay, but because the arm is too short, cannot touch the thrombin, so it has poor interaction, poor inhibitory effect on thrombin. Okay, you don't have to memorize this one. It's just try to explain the mechanism of why the specificity towards factor 10 and 2 is different. And anyway, so this fondaparinix usually we are also known as the indirect factor 10 inhibitors. Because it does not inhibit the factor 10 directly. It needs a cofactor antithrombin here. Okay, but I think what's more important is this slide. This chart compares the characteristics of the heparin, low molecular heparin, and fondaparinix. Okay, let's see from the top about molecular weight. As you can see, unfractionated heparin has the largest molecule, the largest molecular weight, and the low molecular weight heparin, yes, has lower molecular weight, and fondaparinix is a smaller, relatively smaller molecule. And what's important about molecule is that because unfractionated heparin and low molecular weight heparin, they are very large in their molecules. So they do not cross placenta, in pregnant women. So that is why unfractionated heparin and low molecular weight heparin, they are preferred during pregnancy, but not fondaparinix, because this one has small molecular size, so it can cross the placenta. Okay, and let's see this one, for the anti-factor 10 and anti-factor 2 activity, as we have just mentioned, the unfractionated heparin has equal effects towards the factor 10 and 2. But for low molecular weight heparin, it has stronger activity toward factor 10. And for fondaparinix, it is even stronger. So it is very specific toward factor 10. And for APTT, okay, for warfarin, we monitor INR, and INR comes from prothrombin time. And for the heparin, we monitor APTT. For when we use unfractionated heparin, we have to monitor APTT. However, what is good about using low molecular weight heparin and fondaparinix is that there's no need to monitor APTT. This is because they are more specific toward factor 10, and APTT is more associated with reflecting the anti-factor 2 activity. So even if you give low molecular weight heparin or fondaparinix, the APTT won't change much. So you don't have to monitor that. So that is the benefit. I think that is the benefit of using them. Okay, and then let's see the side effects. Because like what we have seen, the heparin is a long molecular chain, right? And it carries a lot of negative charge. So heparin can bind to many things in the blood circulation. It may bind to many proteins or even albumins, and also binds to the endothelial cells of the vessels. So you can see that the one that I marked in blue, yes, it has the unfractionated heparin has the highest protein binding and endothelial cell binding, and because of that, it may also bind to the platelets. So that's why unfractionated heparin may also inhibit the platelet function. And also because binding to endothelial cells, so it may increase the vascular permeability. So altogether, it will contribute to the hemorrhagic effects. So that's why unfractionated heparin has higher risk of hemorrhage. Okay, and in terms of the elimination, low molecular weight heparin and fondaparinux are primarily eliminated by kidney. But for unfractionated heparin, most of them are metabolized when they are binding to other things, like binding to endothelial cells or binding to other proteins. And when they bind to them, there will be enzyme in charge of degrading the unfractionated heparin. So their elimination mechanism is different. Okay, and for the half-life, unfractionated heparin has a shorter half-life. And for the route of administration, this is also important. For unfractionated heparin, usually we give IV by IV. IV is preferred. We do not give the subcutaneous is not preferred, because just like what I have mentioned, because unfractionated heparin can bind to so many things. So if you give it by subcutaneously, then a lot of unfractionated heparin will be destroyed, and the fraction that can really be used will be just very few. Okay, but for low molecular weight heparin and fondaparinux, because they don't have such problem, so they can be given by subcutaneously. So that is also very convenient. Okay, and for antidotes, one benefit about unfractionated heparin is that it has the antidotes. The antidote is protamine sulfate at the bottom. And however, for low molecular weight heparin, protamine sulfate is only partially effective. But for fondaparinux, there is no antidotes. Okay, and this is also a very important chart. It summarizes the oral form anticoagulants and also the parenteral form anticoagulants. Let's see the oral form first. The warfarin is here, and the one in the middle are what we have mentioned previously, the direct oral anticoagulants, the direct thrombin inhibitor or direct factor 10 inhibitors. Okay, you can see that warfarin has longer. It takes time for it to take effect, and also has longer half-life. However, warfarin, most of them are eliminated by the liver. So when a patient has renal dysfunction, you can still use warfarin because it is not much eliminated by the kidney. And for this one, the direct oral anticoagulants, even though we are not using now in the country, but you still have to know that, because one day you may start to using that, because these drugs may come to the country one day, because they are very popular around the world right now. For the direct oral anticoagulants, they have similar efficacy compared to warfarin. However, they have many other benefits. For example, they have a shorter half-life and quicker onset, so it will be easier for you to adjust the dose, or even to monitor, or even for the monitoring. You still have to monitor when you give the drug. However, because the half-life is shorter and onset is quicker, so you don't have to, so it will take less work for you to monitor. You don't have to monitor all that often. And aside from that, because the DOACs the direct oral anticoagulants, they are more specific to the factor 2 or 10. So they have a less hemorrhagic risk. The major bleeding episodes will be fewer. So that is also a benefit. However, the downside is that some of the DOACs, they are largely eliminated by the kidney. Like this one, the dabigatran, or 80% are eliminated by the kidney, and also endoxaban. So that will be so what you will have to be aware of that is that for patients with severe renal dysfunction, you have to avoid using them. Okay, and let's take a look at the parenteral anticoagulants. Yes, the heparin is here and enoxaparin is here, and enoxaparin is also largely eliminated by the kidney, 40%. So you still have to be careful when for patients with renal dysfunctions. And what is important is that enoxaparin is usually preferred for patients with cancer. Okay, and for heparin, what you have to know is about this one, the HIT, known as heparin-induced thrombocytopenia. It is an autoimmune reaction. It is caused by the body produce the antibodies against heparin, so it will lead to thrombocytopenia. And for the most serious situation, it may progress to thrombosis. So that is definitely not the situation that you want. So heparin, you have to be aware of such adverse effect. And when there's HIT, the heparin-induced thrombocytopenia occurs, usually if we have the direct thrombin inhibitors in developed countries, we will use the parenteral from direct thrombin inhibitors for the situation of heparin-induced thrombocytopenia. Because under that situation, you may have to stop the heparin therapy. Okay, so those are about the venous thrombosis, the anticoagulants. And the next part we are going to look at is the antiplatelet therapy. Okay, and they are primarily occurs in the arterial thrombosis. Okay, this picture illustrates what is happening, for example, during the rupture of atherosclerotic plaque. And you can see that when there is a rupture of atherosclerotic plaque, there may be the exposure of the subendothelial components such as von Willebrand factors or collagens. And these factors will activate platelets. It will attract platelets and activate them. And what you will see is that when platelets are activated, it can produce substances such as ADP and thromboxane A2. And these agents, ADP and thromboxane A2, they are soluble. They can circulate in the blood circulation. And however, they are also the activators of platelets. So ADP and thromboxane A2, they can further go to other platelets and activate more platelets. So that is the mechanism of the platelet activation. Okay, and aside from that, when the platelet is activated, you can also see that there is also a glycoprotein known as GP2B3A that is on the surface of the platelet. It will also be activated, and this GP2B3A, they can bind to fibrinogen and act like a bridge, and fibrinogen will act like a bridge, and the GP2B3A will like a hand. So each platelets, they can like holding hands, they can aggregate together by the activation of the GP2B3A and fibrinogen. Okay, and of course also at the same time, during the rupture of the plaque, there is also the tissue factor released from the plaque and therefore generate thrombin. And thrombin, thrombin is in charge of the coagulation cascade, and it will form the fibrin clot. So altogether, at the end, the fibrin clot will cross-linking all together with the aggregated platelets, and therefore forms this one, platelet thrombus. Okay, and so now let's take a look at the targets of the antiplatelet therapies. I think aspirin. Okay, aspirin is the most famous one. Okay, aspirin is here. Aspirin can inhibit the COX-1, and COX-1, this enzyme, is in charge of the generation of thromboxane A2. So aspirin can inhibit the generation of thromboxane A2. And aside from that, you can also see, we have mentioned ADP. And there's another class of antiplatelet therapy that is the P2Y12 antagonist. And they include things such as clopidogrel, prasugrel, or ticagrelor. Okay, they are the P2Y12 receptor antagonist. The P2Y12 is the ADP receptor, so it can blocks the activation of the downstream effect of the P2Y12, because the activation of P2Y12 will further activate platelets. And aside from that, there's also another class that can inhibit PDE, the phosphodiesterase, the cilostazol and dipyridamole. They can block here, and also blocks the activation of platelets. Okay. So this is the brief, general treatment strategies in acute coronary syndrome. Okay, aside from the acute supportive care and reperfusion, no matter in the acute management or secondary prevention, we very often use antithrombotic therapy. As you can use, for example, in the acute management, we may use aspirin, the P2Y12 inhibitors like clopidogrel, we have just mentioned, and very often we may also use the dual antiplatelet therapy known as DAPT. This is the combination of aspirin plus a P2Y12 inhibitors, and also glycoprotein 2B3A inhibitors may also be used. And sometimes in the acute management, we may also use anticoagulants. And but for the secondary prevention, yes, the antithrombotic therapy plays quite an important role, especially the DAPT, the aspirin plus P2Y12 inhibitor. Usually we use them for at least 12 months. And evidence have shown that it can lower the risk of major adverse cardiac events afterwards. Okay, and let's take a look at aspirin. Yes, we have mentioned for the mode of action, aspirin is irreversible COX-1 inhibitors, and usually used in acute coronary syndrome or stroke. And the DAPT therapy, is usually means aspirin plus a single P2Y12 inhibitors. And for the adverse effect, I think most of you have already known, yes, the most famous one is the GI discomfort or GI bleeding. And this is caused by the inhibition of the prostaglandins responsible for GI protection. And so in order to prevent such adverse effects, there are several approaches we can use. One is to use lower dose, and the other is to use enteric-coated aspirin, which means that the dosage form is designed to be released. The active ingredient will not be released until the drug enters the intestine, so that it will pass the stomach and won't influence the stomach. Okay, I'm not very sure if we have the enteric-coated aspirin in Swaziland, but it is very popular in many countries because it can reduce the GI side effects. Okay, so and aside from that, we can also give PPI, the proton pump inhibitors, for patients with a history of GI bleeding or using triple therapy. that. Triple therapy means that you use, for example, you use 1 aspirin plus 2 P2Y12 inhibitors. Okay, and so if aspirin cannot be used, what you can use as an alternative is clopidogrel. Now, for patients who are hypersensitive to aspirin or have intolerance, GI intolerance towards aspirin or the history of upper GI bleeding, what you can do is to give clopidogrel as alternative. Okay, and so these drugs are also quite important. They are the oral P2Y12 receptor inhibitors. Okay, clopidogrel is here. And aside from clopidogrel, we also have the prasugrel and ticagrelor. These drugs are quite expensive because many of them are still under the patent. They still under the patent protections. But after their patent expire, they may start to be cheaper. So one day you maybe start using them. But right now, I think we don't have like this one, prasugrel, ticagrelor here. Okay, but clopidogrel is an older drug, so you have to know that. Clopidogrel, yes, it is a irreversible P2Y12 inhibitor, and what is special about this one is that clopidogrel is not the drug is not in an active form. It is in a prodrug form, which means that after you take the drug in the body, your body have to metabolize and convert the drug into an active form. So, and when the body is activating the clopidogrel, you need the enzyme, the CYP2C19. This is also a liver enzyme. Yes, so the reason why that I mentioned this enzyme is because for some patients, if they have the genetic polymorphism, they have poor activity of this enzyme, then the effect of clopidogrel on these patients will be lower, will be reduced. And also because of this enzyme, so there is important drug-drug interaction for the, PPI we are very often used, like omeprazole and esomeprazole. Esomeprazole is similar to omeprazole. Yeah, they are CYP2C19 inhibitors. So if you are using, so this one can inhibit the activation of clopidogrel. So they may have the interaction. Okay, and I think this is the last slide. Okay, and these agents are also very often used in ischemic stroke. Like in the acute management, we may use alteplase. This is TPA, and aspirin. And for secondary prevention, we may use the antiplatelet therapy. This is usually used for non-cardiogenic stroke. However, for cardioembolic cause of stroke, we may also use the anticoagulants, such as the ones we have just mentioned, the warfarin or the thrombin, the factor 10 inhibitors. We may also use that for secondary prevention. Yes, but what you have to be aware of is that when you are using the new direct oral anticoagulants, you may have to adjust the dose when the patient has renal dysfunctions. Okay, and I think this is the end of my part. Thank you. Okay.
Any questions about the pharmacology, the drug mechanism?